Okay, let's tackle the respiratory system, and we'll start off with respiratory anatomy. Again, this is asynchronous. Try to take notes on questions. You're welcome to shoot those questions to me by email. If I have some help, I may be able to answer them. If I'm not, you're welcome to postpone taking the exam on the respiratory system until after we meet on Monday, the 27th. No, Monday the 26th. Next Monday. To answer any questions, you can take the exam after that, and we'll continue on that day with a lecture on phonation. The vital function of the respiratory system is to maintain life, to keep us alive, to distribute oxygen to vital organs, to then exchange that oxygen for carbon dioxide and to expel that from our bodies. And so the vital function of the respiratory system is breathing for life. The secondary purpose is to provide air power, an airstream of to set our vocal folds into vibration. In order to do this, our lungs draw in air, which can be termed ingression, and that will eventually become a source of energy upon the egression flow, or the outgoing of air from our lungs, or outgoing of air from of carbon dioxide, in order to blow our vocal folds apart and begin vibration, or for that airstream to flow relatively unobstructed through our glottis, the opening between our vocal fold, and provide a source of noise that can also be used in sound creation. I'm not correct. Now, throughout the lectures, we're going to refer to ingression fairly similarly to inhalation and inspiration. Egression will also be used in the same manner as exhalation or expiration of air during the respiratory process. So we have the power supply from our lungs. That power supply can either oscillate our vocal folds or flow through our glottal area, the space between our vocal folds, into our oral cavity for obstruction or occlusion, and then release to create a periodic sound. If our vocal folds are closed, the air supply, or the flow of air, will vibrate our vocal folds, creating a periodic sound, which will flow through our vocal tract, which is the resonator or resonators, and will output a speech sound. There are certain sounds, particularly voice consonants, that require periodic sound and aperiodic sound or noise from our oral cavity or nasal cavity to be modified within the vocal tract to produce voice consonants. Let's talk about thoracic expansion. When we inhale, oxygen, we need space. We need space within our lungs for the oxygen to occupy. So we need our chest area to expand, our thoracic cavity to expand. When it expands upon inhalation, it will expand vertically, meaning that our diaphragm will lower, making room for our lungs to expand. Our chest wall will expand sideways or transversely, and it will also expand towards the front as our rib cage expands. It will cause our chest cavity to expand posteriorly to the front and to the back. And again, make sure that you're viewing the videos that are embedded in the PowerPoint, and you can do that by downloading the PowerPoint, saving it, placing it in the presentation mode, and clicking on the link. This is an image that depicts chest expansion. We're able to see it expand anteriorly, and we're able to see it expand vertically by the depression of the diaphragm, and when the diaphragm moves upward in order to compress the lungs to force the carbon dioxide out of our bodies. What we're not able to see is a transverse or side-to-side expansion because of the sagittal nature of the previous image. Okay, so let's look at the vertical expansion created by the diaphragm, which is muscle and tendon. So when we are inhaling oxygen, our diaphragm will move downward, allowing for our lungs to expand. Our chest will move anterior, kind of upward and out. Upon exhalation, with the carbon dioxide leaving our bodies, we need our diaphragm again to move vertically, this time up. Our chest or rib cage will now move downward, actually posteriorly downward, compressing our lungs and forcing the carbon dioxide out. Inside the chest wall includes our pulmonary system, which involves our rib cage, the diaphragm, the wall of our abdomen, the organs of our abdomen, our abdominal viscera, and muscles of the chest and abdomen that we'll be talking about later. The trachea, and as we go out this term, I want to make sure that when you are completing any assignments or exams that you're using the formal anatomical term as opposed to lay term for anatomical parts. So this is your trachea. It then divides into bronchi, or the right bronchus and the left bronchus, and the bronchi divide into bronchioles, smaller tubes, and eventually terminate at the alveolar air sacs, which are the outermost parts of the respiratory system or our lungs, where carbon dioxide and oxygen are exchanged. Also within the thoracic cavity and within the rib cage is our mediastinum, which contains our heart, major blood vessels of the heart, and your esophagus. The outer lining of your lungs are your pleural membranes, and these are very thin, airtight membranes that encase your lungs. Between your lungs, between each pleural membrane is a pleural space that increases and decreases, but also within that pleural space is contained negative pressure, and we'll talk about that a little bit later. The outermost membrane is the parietal pleura. The innermost membrane is the visceral pleura. Your pulmonary system for each lung has lobes. The left lung has 2 lobes, the inferior and superior lobe. The right lung has 3 lobes, the inferior, middle or medial, and superior lobe. Again, this is your trachea, right bronchus, left bronchus. The anatomical plane depicted here, is it transverse, sagittal, coronal, or medial? And it is coronal, number 3. The chest wall expands. Is it anterior posteriorly, vertically, transversely, or all of the above? It is all of the above. What passes oxygen into the bloodstream on inhalation and releases carbon dioxide on exhalation? Is it our bronchi, alveolar sacs, diaphragm, or lobes? The answer is 2 alveolar sacs, or alveolar sacs. Okay, you have 2 videos here to watch, respiratory pressure and intrapleural pressure. Again, we're speaking of the 2 thin membranes that line the ribs. In between is a pleural space that contains negative pressure. That pressure must decrease so that the pleural space will decrease, allowing for your lungs to expand on inhalation. However, for exhalation, the pleural space is allowed to increase. Therefore, the negative pressure between the 2 membranes will increase, allowing your lungs to deflate, but not completely. So, for expiration, we need the intrapleural pressure to increase. For inspiration or inhalation, we need the intrapleural pressure to decrease, allowing for additional expansion of the lungs. Alveolar pressure that's applied to the alveolar sacs during expiration must increase, allowing for the carbon dioxide to be pushed out of our lungs. Conversely, alveolar pressure will decrease during inspiration or inhalation so that oxygen is allowed to flow into them and through them into the bloodstream. So, intrapleural pressure and alveolar pressure decreases with inhalation. Alveolar pressure and intrapleural pressure increases upon expiration. Our chest wall expands, or the thoracic cavity expands during inhalation as a result of muscular contractions, and we'll talk about those muscles briefly. Expiration not only uses muscle contractions, but it also has passive forces. One passive force is gravity. Whatever goes up, chest cavity goes up, it must come down. There's also an additional passive force that is created by the untwisting of the ribs cartilage that is attached to your sternum in the front and to your backbone in the back. These are your ribs. You have 12 pairs. 10 of those pairs attach to your sternum via cartilage, which you see in blue, and in the back to your breastbone, to your backbone. There are 2 sets of ribs that are considered to float, meaning that they are not directly attached to your sternum by cartilage. The cartilage that are attached to those 2 sets are attached to the cartilage of the ribs that are superior to them. When you inhale, your rib cage moves upward and outward, and your cartilage will twist as it's moving upward. Upon expiration, as gravity brings your rib cage down, as muscles of expiration brings your rib cage down, you will also have a passive force whereby when these cartilage untwist, there is a force that is created with that untorquing, also providing force to compress your lungs and expel carbon dioxide. These are the muscles of inhalation. You will notice later that there are also muscles of inhalation that participate on expiration. And actually, during deep breathing or loud speech, both sets of muscles for inspiration and expirations are used for that cycle. Let's take a look at we've talked about your ribs, the cartilage now that's being depicted in gray. This is your clavicle. Your sternum, the manubrium of your sternum, and your xiphoid process, which is the inferior portion of the body of the sternum. Typically during respiratory distress, or when a person is breathing inefficiently, we call that clavicle breathing, where more emphasis is placed on raising the upper chest during thoracic expansion for the vital function of breathing. And you will notice for some individuals that their skin will depress right above their clavicle when they are using clavicle breathing, and that's usually during respiratory distress that is preventing them from expanding their entire portions of their lungs. Let's look at the first couple of muscles that are used during inhalation. You have your external intercostals that run from the lower border of one rib into the upper border of an inferior rib to the lower border of a rib that's superior to it. Your internal intercostals also help with raising your ribs. However, its action comes into play during deep breathing. These two muscles you will not be responsible for identifying. It's just too difficult on most images that I use for test. So know that of the muscles of inspiration, your external, internal intercostals will not be depicted in a labeling exercise for your exam. There are muscles or posterior muscles that are also participants in inhalation. Your levator's cantarum, sorry about that, elevate your ribs. They originate from your vertebrae and insert to a rib below, helping to lift the ribs during inspiration. There are 12 sets of those muscles. Additional back muscles are your serratus posterior and your latissimus dorsi. The serratus posterior superior muscles insert into your second and fourth rib from your neck and help to lift your ribs. The latissimus dorsi originates from your upper arm and inserts into your lower back. There are muscles of the neck that participate in inhalation or inspiration. Your sternocleidomastoid originates from your mastoid bone, which is behind your ear at the base of your skull, and inserts into your clavicle and to your sternum. The scalene group is a set of 3 muscles, anterior, medial, and posterior, and they insert into the first and second rib, helping to raise your chest and to stabilize it. The subclavis also helps to raise the chest, sub meaning below, clavis meaning your clavicle. So below your clavicle, this is your clavicle, is your subclavis. Your pectoralis major and your pectoralis minor that rest below your pectoralis major also help to raise the ribs during inhalation. Another image depicting full inhalation, exhalation with the chest wall coming down, depressing, and your diaphragm moving up, compressing your lungs, forcing the carbon dioxide out. These are the muscles of expiration. And if you notice there, the latissimus dorsi is there. It also participates in expiration. If you notice, there are 5 muscles that are in bold. The internal intercostals, again, you will not be responsible for identifying. However, you will be for the thoracic, the transverse thoracic, the external oblique, the internal obliques, and the rectus abdominis. So let's take a look at those. The flat sheet of muscle here is your rectus abdominis. Your external obliques, under your external obliques, is your internal obliques, your transverse thoracics. Now, we talked about the process of inspiration where your rib cage raises the cartilage of your ribs, twist. Your viscera or your internal abdominal organs are compressed due to the lowering of your diaphragm, and your alveolar sacs are allowed to inflate due to decrease alveolar sacs pressure. Upon relaxation or exhalation, you have gravity that brings your rib cage down. You have another passive force where your cartilage untwists. And a passive force is a force that you're not in control of. You're not in control of gravity, nor are you mindfully untwisting your cartilage. The spongy, elastic, the sponginess of the lung tissue will recoil. Your abdomen will deflate your lungs by your diaphragm pushing upward. Alveolar pressure during expiration will increase in order to expel carbon dioxide. And relaxation pressure, if you would take a deep breath and then just relax, your rib cage will come down due to gravity and untorquing of the cartilage. Alveolar pressure will increase because your alveolar sacs are being compressed also in order to expel carbon dioxide. I'll have you guys take a look at this. It won't be on your test, but as you're getting sleepy or drowsy, you tend to lower your respiration rate or the intake of oxygen. Your brain then senses that you need oxygen and sends a message to your body to take a deep breath or a yawn. You sneeze in order to expel items that may irritate your mucous membrane lining of your nose, such as pollen or dust. And hiccups are caused by irritation of your diaphragm that will cause involuntary contractions, perhaps by substances that have been received into the blood based on perhaps food that you've eaten. So let's look at some questions. Negative pressure between the two pleural membranes is called interpleural pressure, intrapleural pressure, inspiration, or expiration. It is called 2, intrapleural pressure. Which is not involved in inspiration? Your external intercostals, pectoralis minor, your rib cage, or your thoracic, transverse thoracic. It is 4, your transverse thoracic. Upon relaxation pressure, your rib cartilage twists, your diaphragm moves downward, your rib cage is pushed outward, or passive forces exist. It is 4. Passive forces exist. Okay, let's take a look at the function of the respiratory system or the physiology. Okay, great. So did you know that when a baby is born, chemical reactions occur that initiate the respiratory pattern of regular breathing? And it takes several days for a newborn and possibly several months for a premature newborn to achieve full respiratory efficiency. This is another video on vital capacity for you to view. Now, with regard to lung physiology, we're going to talk about volume, or you can think about the space used during the respiratory cycle. And so vital capacity is the measure of the capacity of the lungs to expand during inhalation. This can be as the amount of vital capacity is dependent upon the actual volume of lung tissue, how large your chest is, the circumference of your chest, the size of your chest circumference or lungs usually peaks around late teens to early childhood. Then as we age, that measure decreases and your diaphragm action reduces some. Actually, in elderly individuals, your lungs are positioned lower in the thoracic cavity than before. Your vital capacity is the functional capacity of your lungs to expand during maximum inhalation and maximum exhalation. Again, your vital capacity is, or your functional lung capacity is, the ability of your lungs to accommodate the air that is inhaled, maximum air during inhalation and during exhalation. It is extremely rare that you can reach the outer limits or the limits of your vital capacity. The amount of air that you use typically is called your tidal volume. After each maximum expiration, preceding or following a maximum inspiration, there is a volume of air that continues to reside, or there is a volume within your lungs that continue to reside that is part of your total capacity that is never exhaled. I'll come back to that in just a second. Let's take a look at this. So if we could think about the total volume of your lungs, there is a volume that is a little over a fourth of your total volume. Your total lung capacity or ability to take in or make room for air is 7 liters. 2 liters of that is residual volume that is never used normally. The remaining 2/3 to 3/4 of that volume is called your vital capacity, which includes quiet, tidal breathing, quiet breathing, inhalation, exhalation. However, when we need to take a deep breath, we are then tapping into additional volumes of air in our vital capacity for a deep inspiration followed by a deep expiration. And when we are dipping into those additional reserves of inspiration and expiration, we okay, let's go back. All right, so the vital capacity for children, actually, with the exception of preteens, the vital capacity is typically more for boys, over from 5-year-olds to 7-year-olds, or the vital capacity is greater for boys than girls. Okay, so vital capacity is the maximum volume of air that we use during inhalation, maximum inhalation and maximum exhalation. However, typically when we're not active, when we're not talking, we're using quiet respiration, which uses less volumes of air within the vital capacity. So we bring in air and then expel it due to muscle forces and the passive forces that we talked about. The duration of time that it takes for you to inhale during quiet breathing and exhale doesn't differ significantly. The volume of air that we move in and out during this time is called the resting tidal volume. So right now, while you're listening to me, you're using your resting tidal volume. Forced respiration is when we need to use more volume of air in order to support physical activity and speech. So we need all our muscles of inhalation to assist our diaphragm and external intercostals, allowing for our thoracic cavity to expand during inhalation. And we need active forces of muscles of expiration along with passive forces to help force carbon dioxide out during expiration. Anytime that we use volumes of air beyond our resting tidal levels, we consider this forced expiration. We're still within vital capacity, yet we are using volumes of air, usually about 2 liters in more of within our vital capacity, more than our resting tidal volume during forced respiration. During forced respiration, again, we're taking in more air, so we're breathing in deeply, and we're using more muscles in order to help expand our thoracic cavity. Again, we have a residual volume of air that remains after every maximum expiration, so it's not possible typically to expel the entire volume of air within your lungs. This residual volume increases with age, although it doesn't appear to impair the function or breathing function of most elderly individuals. This is another depiction. If we could look at the bar on the right, this would represent your total lung capacity. Within your total lung capacity, you have your vital capacity and your residual volume. Within your vital capacity contains volumes of air needed for quiet breathing, and your inspiratory reserve and expiratory reserve that you use during forced respiration and also for speech. So we need, beyond the resting tidal volume of air, we need to use our reserves for speech. We need forced air or forced carbon dioxide to vibrate our vocal folds, or we need it to create either burst of air, creating noise, or creating resistance to air pressure within our oral cavity, creating an aperiodic sound. Research has shown that for forced respiration, we are using inspiratory and expiratory muscles for speech. So we need greater volumes of air for speech, and particularly even greater volumes of air within that vital capacity for loud speech. So for loud speech, we need to blow our vocal folds farther apart, so we need more air, more volume. Again, during quiet tidal breathing, the time spent of inhaling and exhaling, 40% of that respiratory cycle is inhaling, 60% is exhaling. But because we use the air from during exhalation to vibrate our vocal folds, during the respiratory cycle, we will use 90% of that for expiration and only 10% for inspiration, because we speak on expirations. This is for quiet respiration, the time taken during a respiratory cycle, but for speech, we need 90% of that respiratory cycle to be for expiration in order to sustain speech. So we need to breathe in quickly in order to sustain speech. So speech occurs on exhalations or expirations, and we're using minimally both sets of expiratory and inspiratory muscles, particularly at the beginning. During speech, we are using increased alveolar pressure, and active expiratory forces in terms of muscles are required to compress our lungs and increase alveolar pressure to force carbon dioxide on expiration to vibrate our vocal folds. So while we're breathing for life and meeting requirements for speech, we are altering our respiratory pattern in order to vary elements of speech. So for instance, if we need to speak in longer phrases, then we will need more volume of air. If we need to speak in louder, we will need more volumes of air. So the volume of air must volumes of air differ depending on the characteristics of speech that we're using. Now, the rate in which we're breathing, or the frequencies of the frequency in which we're breathing in and out, expiration, inhalation. If we're breathing more frequently, if the cycles are occurring more frequently, then we're only able to use smaller volumes of air. And therefore, if we're breathing more frequently using smaller volumes of air, and we speak on volumes of air, then our phrases will be smaller. So in order to sustain a phrase, we have to be able to sustain the exhalation. So if the volume of air upon exhalation is smaller, then our phrase must be smaller, or we'll run out of air, and we're not able to phonate the rest of the phrase. Duration, if we need a longer phrase, then we need a longer time of expiration. The louder the speech, the more volume of air needed, and we need resistance of that air pressure in order to achieve the desired loudness. So, upon speaking, your vocal folds are closed, and we need increased pressure from the outer limits of our lungs to be applied to our velar sacs, which increases the pressure, velar pressure, which forces carbon dioxide out. As that carbon dioxide flows through our bronchioles, our bronchi, up the trachea, and there is pressure that builds under our vocal folds. And that pressure is then released, blowing our vocal folds open. And so, in order to achieve that resistance, we need more pressure applied to our velar sacs. If there is no variation in loudness or the pitch of our voice, and we're using monotone speech, then we just need a steady flow of a velar pressure being applied to our velar sacs. However, if we want to apply any type of stress to speech, whether that stress is increasing the pitch, increasing loudness, or extending the duration of an utterance, then we need more velar pressure. Vowels are louder than consonants, not necessarily due to an increase in velar pressure. It is an increase in intraoral pressure within the oral cavity. So the rate at which we inhale and exhale can affect speech. And so if we're breathing too fast, then we're only able to speak on short phrases. So the rate of a breath for one speech depends on the length of the phrase. So if you're speaking a long, louder phrase, it will require you to breathe slower per minute and with deeper inhalations. So if you notice, if you're working out or you're participating in strenuous activity, your respiratory rate increases, and therefore it is very difficult for you to speak louder and in longer phrases. So we know the duration of time is fairly similar when we're breathing for life, but for speech, we need longer expiration than inhalations for louder speech. Or for breathy speech, or when you're attempting to whisper, you need shorter expirations. This graph depicts the volume of air used within our vital capacity when we're resting, breathing quietly. We're a little bit at about 40% or a little bit above. When we're speaking at an average conversational volume, we're using maybe about 65% of the vital capacity. However, when we're speaking loudly, we're using about 80% of the vital capacity upon inhalation. So, things to remember. Relaxation pressure or passive expiratory forces due to gravity. Recoiling of the lung tissue and the untwisting of the rib cartilage occurs during relaxation pressure. But as we need more volume of air in order to speak on louder and longer phrases, the greater the volume of air needed and active pressure or active respiration is needed in that case. Now, there are several disorders whereby individuals with those disorders use inefficient volumes of air. Individuals with severe hearing loss have typically, there's no relationship between hearing loss and respiratory disease or respiratory function. However, if you have a severe hearing loss, then your attempts to hear speech is difficult. So speech always sounds quiet to you. And so remember, if you're producing quiet speech, then you're speaking on lower volumes of air than if you were using louder speech. And so when individuals with severe loss are attempting to develop speech and language, they are mimicking what they're hearing. And so therefore they tend to speak on lower volumes of air because they're patterning that off of their perception of the level of speech that they're able to hear. Fluency disorders are not to say that if you have a respiratory disease that limits your lung volume, that you'll have a fluency disorder. Individuals with fluency disorders typically have normal lung function, although they are using their lung volumes inefficiently and causing their speech to be disfluent. Disfluent with regard to intensity, duration, smoothness. Motor disorders can actually affect the function of your lungs' ability to breathe in adequate volumes of air for speech. And so with cerebral palsy, your muscles of inspiration and inhalation may not function normally, therefore not allowing you to expand your thoracic cavity, allowing for the volume of air needed to produce speech. Okay, so let's look at some questions. Respiratory pressure is needed, or respiratory pressure is needed for changes in the blank of speech. Is it the pitch, loudness, or duration? It is for all of the above. Resistance to the flow of air pressure is needed to produce vowels. Is it caused by relaxation pressure, changes in alveolar pressure, or intraoral pressure? Or is it 2 and 3? It is 3, intraoral pressure. The louder the speech sound, is it the shorter the expiration, the longer the expiration, decrease in lung volume, or none of the above? For the production of loud speech, you need longer expiration. A longer phrase requires slower respiration, faster rate of respiration, shallow inhalation, or a decrease in lung volume. For a longer phrase, you need slower respiration, number one. And the last one, which lung volume is not contained within the vital capacity? Is it inspiratory volume, expiratory volume, residual volume, or tidal volume? And the answer is 3, residual volume. Okay, again, please make sure that you review the handouts, all of the content under respiration in the content area of eLearn. Review the PowerPoints. Hopefully you have your books by now to review your books. Watch the videos. If you feel comfortable taking the test before we meet next Monday, please do so. If not, be prepared to bring your questions. We'll address those at the beginning of the lecture, and then continue on with information about phonation. And you're welcome to take the test in the following days. If you shoot me an email, I can't promise you that I'll have someone that will be able to help me answer that. So hopefully, if you are still unsure and you're not able to get that clarification, then you're welcome to wait until next Monday. So have a good rest of the week. I'll attempt to grade as many tests that are completed before Monday morning, the 19th. If not, if you've not completed the test on acoustics and the preface, then it may not be graded until later this week. Have a good rest of the week.